Good morning, everybody. Thanks for being here and for joining us. And today, for the next half an hour, I'll be talking about the cardiac anatomy with the focus on the features that are relevant and important to us in the EP lab, and of course, to a degree, some degree, to the cath lab. And I'll try to highlight the important points that are relevant to our daily practice, and also for those who are seeking certifications in RCES or IBHRE. If you have any questions, you can type your questions in the chat part of the Zoom, or you can ask at the end of the lectures or anytime. So I'm going to start from the pericardium. We can think of the pericardium as the sac in which the heart muscle lives. And that sac is a fibrous sac, and you can see it here attached to the roots of the great vessels of the heart. So this is the sac, this is the pericardium. The heart is within that sac, and you can see the attachment of that sac to the great vessels. In this case, this is the pulmonary artery, this is the aorta, this is the SVC. If we enlarge that area of attachment, we can look here and we can see the outer layer of the pericardium, which we call the fibrous pericardium, very thick, very tough layer. And as it attaches to the root of the great vessel, it reflects at that point and goes back and attaches and adheres to the surface of the heart muscle. The inside layer is a thin serous pericardium layer, and that is the one that's also adheres to the heart muscle. We call it the visceral layer or the epicardium in that area. In between these two layers, we create a space. We call it a pericardial cavity. And in this space, there's a small amount of the pericardial fluid that will allow the heart to beat and slide without difficulty. So this is a normal pericardium. If we take the heart out of the pericardial sac, we can see the vessels we talked about. This is the pulmonic artery, this is the aorta, this is the SVC, this is the IVC, and these are the four pulmonary veins. And the line here around those veins where the pericardium reflects and go back to the heart, it creates what we call sinuses. This is the oblique sinus, and there's another sinus here, we call it the transverse sinus. If we go in the pericardial space and we put a catheter in between the pulmonic artery and the pulmonic vein here, the catheter can slide across to the other side. But if we put it in between the left superior and the left inferior pulmonic vein, we cannot cross. And if we put it in this oblique sinus and try to push up, we cannot. So we need to be aware of this anatomy. So this is the pericardial space when we remove the heart. And to realize how tough that pericardial tissue is, especially the fibrous one, this is basically when we try to get to the pericardial space to perform epicardial ablation. So this is the needle. We're coming through a subxiphoid approach. When we feel the resistance, that's when we know we are hitting the pericardium, and that's when we inject contrast. And you can see the tenting with the needle of that fibrous pericardium, and we feel that resistance. And as we cross, that's when we inject a small amount of contrast and see free layered contrast. That's when we know we reached the pericardial space. Of course, we are entering a dry pericardium in this case, and we need to be very careful not to puncture the right ventricle. After we enter the pericardial space, that is when we advance the guide wire, you see here, into the pericardial space and advance the sheath over it. And through that sheath, we put our ablation catheter into the pericardial space. So it's important to understand the pericardial anatomy because we use it in EP to reach the pericardial space for an epicardial approach for ablation. This is a CT scan of a patient. This is the patient with the normal heart, and you can see this is the pericardium around the heart. This is the sternum, and this is the back here. And you can see here amount of fluid. This is pericardial effusion and or tamponade. When you have large pericardial effusion, you can cause tamponade depending on the volume of the pericardial fluid. If the bleeding, for example, occur acutely as a complication of a procedure, you don't need much pericardial fluid to cause tamponade. If it is slow process, such the one you see in people on dialysis or in patients with cancer, the process is very slow, and that will allow the pericardial sac to expand. It allows it time to expand, so you can accommodate a large amount of fluid before collapse of the right ventricle and before having hemodynamic consequences. Nonetheless, from an EP standpoint, pericardial effusion and tamponade is a major complication that we see potentially in any ablation procedure, but we tend to see in a common procedure we do, and that is atrial fibrillation ablation. But you can also see it as a result of perforation of the right ventricle with any device lead we implant, whether it's in the right atrium or the right ventricle. And it's important to understand how to access that pericardial space to remove the fluid or the blood and improve the patient's condition. Now let's dive deeper. And if we take the pericardial sac off, and now we expose the heart muscle with its vessels. This is the arterial tree. We all see that. This is the left main, the left anterior descending artery, the left circumflex, and the right coronary artery, and the venous system of the heart. One point I need to highlight, and that is the blood supply of the myocardium is epicardial. It's epicardial structure. And I'm going to focus on the coronary sinus for the EP world. We need to understand every detail we can understand about the coronary sinus, because we put catheters inside the coronary sinus, we put pacing leads inside the coronary sinus, we ablate within the coronary sinus. So let's highlight the coronary sinus a little bit more. This is a posterior view of the heart. You have the left atrium here, the right atrium here, and this is the coronary sinus coursing between the left atrium and the left ventricle. Then it turns around. This is turning around, still between the left atrium and the left ventricle. As it turns around, it accompanies the left circumflex artery, then it curves and goes in between the right and left ventricle along the left anterior descending artery. The body of the vein, we call it the coronary sinus. The continuity of that vein, we call here the great cardiac vein, and then it becomes anterior here, we call it the anterior interventricular vein. The branches we need to understand, the first branch, we call it the middle cardiac vein. Sometimes we have an accessory pathway in that area. We can ablate within that vein. Other branches, we call it posterior or posterior lateral branches. That usually the place where we target to place the left ventricle lead in biventricular pacemaker and biventricular ICD. And there is a vein here that comes off and runs between the pulmonary veins and the left atrial appendage. We call it the vein of Marshall, or the oblique vein of the left atrium, and we'll talk more about that. And this actually, the origin of that vein usually demarcates the beginning of the great cardiac vein and the end of the coronary sinus. And then you have these two veins, for example, or a few veins, could be one or more. We call it the left atrial veins. Rarely we may use those veins to pace the left atrium in case we don't have good place or good target in the right atrium for pacemaker, right atrial pacemaker lead. Let's highlight the coronary sinus again, and I'm going to talk about the the valves of the coronary sinus. So this is the coronary sinus os, the opening of the coronary sinus. We call it the coronary sinus os. This is the body of the coronary sinus. This is the oblique vein or the vein of Marshall. This is the great cardiac vein. And this is the posterior or lateral branch of the coronary sinus, where we put the left ventricle lead. At the opening of that vein, we can have a valve. We call it the Thebasian valve. And the opening of lateral or posterior lateral vein, we can have another valve. We call it Vieussens valve. And that valve could also be in the body of the coronary sinus. Again, at the point of separation, if you will, between what we call the coronary sinus and the great cardiac vein. So the opening of the coronary sinus and the Thebasian valve, this is the different morphologies, can vary greatly. It could be a little crescent, could be a bigger valve, could be almost total occlusion of that vein, could be a little cord, could be fenestrated. We need to know this because that can create a lot of difficulty as we try to cannulate the coronary sinus, whether during the EP study, putting the catheters inside the coronary sinus, or during placement of the left ventricle lead. This is one of our patients. Hopefully you can appreciate. Now this is the right ventricle defibrillator lead. Now we're going to put the lead in the left ventricle. So we engage the coronary sinus and we inject contrast in LAO projection. I hope we can all appreciate this shelf or this lucency here. This is actually the Thebasian valve. And you can probably see it here as well. This first branch here is the middle cardiac vein. And you can probably appreciate the atrial branches here. Now let's talk about the Vieussens valve. This is actually yesterday's case, biventricular ICD placement. We engaged the coronary sinus, we injected in the LAO projection, and you can see the contrast stops here, and this is actually at the level of the valve, the Vieussens valve, and that could be a problem. You need to be careful and aware of this so we don't push. We gently cross this area and advance the sheath if we are to be able to place the left ventricle lead. And this is what happened yesterday. We crossed that valve in this area, and we can see the lateral branch of the coronary sinus, and that's actually where we placed our left ventricle lead. And this is the optimal place for left ventricle lead placement. Another thing you need to know about the coronary sinus, and that is the possibility of having what we call coronary sinus diverticulum. And that could be the site of fibrous or muscle fibers connecting the atria and the ventricles and acting like an accessory pathway. And that will be the site of ablation. So this is the coronary sinus venogram here. You can see the diverticulum here. And this is the ablation catheter, the neck of that diverticulum, ablating the accessory pathway. Let's talk about the vein of Marshall and persistent left superior vena cava. As I mentioned, the vein of Marshall, or the oblique vein of the left atrium, is basically between the coronary sinus and the great cardiac vein, and it courses between the left pulmonary veins posteriorly and the left atrial appendage anteriorly. This is usually a remnant of what we call left superior vena cava. During development in fetal life, if this is the sinus venosus, you have what is called here the anterior cardiac vein. And as we develop and create what we know the anatomy of a normal heart here, this is the right atrium, this is the coronary sinus, this is the left subclavian vein, the left brachiocephalic vein, the SVC, and so forth. If this vein here, which is supposed to disappear with development, if it stays open, that's what we call persistent left superior vena cava. And as a result, the remnant of that vein, which is supposed to create the vein of Marshall, very small vein, becomes very large vein, and it looks like this. So the vein of Marshall normally would be a small remnant, and it could be like a ligament. But if it is not atretic like it's supposed to be, it becomes a very big vein. We call it left superior vena cava, and it's important to recognize this for different reasons. The vein of Marshall could be a source of arrhythmia, causing atrial fibrillation and atrial tachycardia. And if we have persistent left superior vena cava, as you'll see in future slides, it could be an issue when you're trying to place device leads. So this is a 3D reconstruction with CT angiogram. This is a left lateral view, and this is the coronary sinus here. This is left superior pulmonary vein, left inferior pulmonary vein. This is the appendage, and this is the vein of Marshall here. And this is this dot between the appendage anteriorly and the left superior pulmonary vein posteriorly. That is in a normal heart without persistent left superior vena cava. When that vein persists, it looks like this when you inject contrast. So you can see, instead of the subclavian vein going across along the guide wire to the right side, it also goes down, and the vein is big, draining into the coronary sinus, into the right atrium, and causing the coronary sinus to be large. When we try to place pacemaker, for example, there may not be connection between the left and the right. So if you are to place the leads, you have to go through the coronary sinus to the right atrium and to the right ventricle. And we may choose not to do that and move to the right side and place the device on the right side. But we have placed it on the left side, and there's nothing wrong with doing that. This is actually one patient we did atrial fibrillation on. And as you know, before atrial fibrillation ablation, we perform TEE to check for left atrial appendage thrombus. So this is the left atrium. The left atrial appendage here is actually occluded. This patient had aortic valve replacement, and they clipped the left atrial appendage. And we saw this big structure here, and this turned out to be persistent left superior vena cava. And we went ahead and did the ablation anyway. And this is the ablation we did. This is the left atrium, and this is to highlight the coronary sinus. We go inside the coronary sinus and we create 3D reconstruction of the left of the coronary sinus. This is the green color here, and you can see and appreciate how large this vein is, going in between the pulmonary veins on the back and what's supposed to be here, the left atrial appendage. Now, let's highlight the cardiac conduction system. And this is the simplified diagram of the cardiac conduction system. It starts with the sinus node, or think of it as the electrical generator. And then you have the electrical wiring system responsible for conducting the impulse between the atria and the ventricles. And you have the AV node and the right bundle and the left bundle. Just remember, the sinus node is in the top of the right atrium, at the top of the structure called the crista terminalis, and it's closer to the epicardium than to the endocardium. The AV node on the right side with his bundle, then it divides and gives the right bundle on the right and the left bundle that crosses the membranous interventricular septum, goes to the left side under the aortic valve. Keep in mind that the conduction system is endocardial or subendocardial. The blood supply, as we mentioned, epicardial. Also note how thin the right bundle is relative to the left bundle. When we do heart cath, when we do Swan-Ganz placement, we can touch that right bundle. When we place catheters in the right ventricle, we can touch and bump that right bundle. Even mechanical touch can result in right bundle branch block. That's how superficial and that's how thin that bundle is. The left bundle, on the other hand, is a big trunk with a lot of branches, and it's not easy to block that bundle. So if you have a right bundle branch block, in general, it is a benign thing and it can happen at any age, and we don't usually worry much about it. If you have a left bundle branch block, you really need to work this patient up and try to find a reason for that, because it is not normal to have a left bundle branch block, and you can imagine why, because how thick that bundle and its branches, so it's not easy. But for those who are involved in TAVR, when we replace the aortic valve and put a new valve here, which is like putting a stent, the new valve pushes against the left bundle and can create left bundle branch block. So if you are starting with a patient who has right bundle branch block, before you place your TAVR, it's important we place a temporary pacer in the right ventricle and likely need to proceed with a permanent pacer if after placing the valve, we cause left bundle and result in complete heart block. This slide is to show the close relationship between the blood supply, arterial blood supply, and the electrical conduction system. This is the sinus node. This is the AV node, right bundle and left bundle with all its branches. We can see the right coronary artery. It gives a branch to the sinus node, another branch to the AV node. So to remember it, the right coronary artery on the right provide the blood supply to the electrical system or part of the electrical system that's on the right, and that's the sinus node and the AV node. The bundles, they get most of their blood supply from the left anterior descending artery. Of course, there are exceptions and double blood supply to a lot of the some parts of the electrical system. But also when you have a complete heart block as a result, for example, of complete occlusion of the right coronary artery in acute MI, you can understand why that would result in heart block as you stop the blood supply to the AV node, or why would it result in sinus node dysfunction or sinus bradycardia or arrest if the block was proximal enough, proximal to the origin of the branch that supply the blood to the sinus node. Let's talk about the autonomic innervation of the heart. We have a few more minutes, then we will stop at 7:30 or 7:35. So if you take the heart out of the frog's body and put it in a physiologic solution, it keeps beating. That means the heart has its own electrical generator, as we decided, it's the sinus node. But under physiologic situations like exercise, stress, pain, the heart rate goes up, and while asleep or resting, the heart rate goes down. And that is because of the influence of two main nerves. The vagus nerve, which works like a brake that slows down the heart, goes to the sinus node and to the AV node. So the vagal innervation goes to the sinus node and to the AV node. The sympathetic innervation goes also to the sinus node and to the AV node, but also goes to the ventricles. So the vagus or the vagal innervation does not go to the ventricle, only the sympathetic innervation. And that's responsible for acceleration, increasing the heart rate. When we perform carotid sinus massage in people with SVT, we are stimulating the baroreceptors that will cause by reflex the vagus nerve to act on the sinus node and the AV node and slow the sinus node and slow the AV node. And if the AV node is participating in a re-entry circuit and causing tachycardia, that's the mechanism by which, by straining or what we call Valsalva maneuver or carotid massage, we potentially can stop that tachycardia. The sympathetic innervation of the ventricles is also the basis because it can cause ventricular tachyarrhythmia, and in some resistant cases that are difficult to control by different antiarrhythmics and by ablation procedures, sometimes sympathetic denervation has a role in controlling this arrhythmia. Other structures, autonomic structures we need to be aware of, we call it the ganglionic plexi, and that's in the left atrium. You have 4 of them: left superior, right anterior, left inferior, and right inferior. The role of ganglionic plexi in causing atrial fibrillation and perpetuation of atrial fibrillation is an issue of debate, and whether we should target them as the main target for ablating atrial fibrillation. Also, it's not clear, but we do target them, and we have data to show that targeting those structures can help treat atrial fibrillation during ablation procedure. And this is the same posterior view of the left atrium. This is left pulmonary veins, right pulmonary veins, left atrial appendage, and these are the structures we call the ganglionic plexi. And a diagram showing what we call re-entry circuits or low amplitude fractionated electrogram we target with ablation. And those areas of low amplitude fractionated atrial electrogram tend to be in proximity or in the same neighborhood of those ganglionic plexi. And when we hit one of those areas with ablation, you probably remember noticing the heart rate slowing down, even stopping for a few seconds. That's an indication that we are ablating in the area of the ganglionic plexi. Staying in the same area, talking about the nerves, and now this is the phrenic nerves. We have one on the right, one on the left. Both go to the diaphragm and responsible for contracting the diaphragm and helping us breathe. By contracting, the diaphragm goes down, decreasing the intrathoracic pressure, allowing the air to come in for us to breathe, allowing the blood to come in to the lungs, and help in the process of breathing. This is a normal chest X-ray. This is the same patient with elevated right hemidiaphragm because of paralysis and damage to the right phrenic nerve. And if we look at those 2 phrenic nerves, the one on the right and the one on the left, we can see the anatomic relationship of the right phrenic nerve to the cardiac structure. You can see it very close to the SVC and close to the lateral edge of the right atrium. This is the right atrium. And also, these are the pulmonary veins on the right. So when we ablate in these areas, we need to be careful not to damage this phrenic nerve so we don't get paralysis on the right side. The left phrenic nerve, we can see its proximity to the left ventricle wall, not to the left atrium or the right atrium. And the chance of damaging the left phrenic nerve is higher when we are doing epicardial ablation in the left ventricle, when we access the pericardial space through that subxiphoid approach we discussed in earlier slides. And that phrenic nerve on the right usually courses between the SVC, posterior to the SVC. This is posterior view of the heart, left atrium, right atrium, SVC, IVC. To the SVC, then it turns around in between the right superior pulmonary vein and the SVC along the lateral wall of the right atrium. So it's important when we are ablating in the right superior pulmonary vein especially when we do cryoablation. If you remember, we stimulate the phrenic nerve to make sure as we are ablating, we are not damaging that nerve. Also, if we are ablating in the right atrium, an area that could be close to the phrenic nerve, it's important to stimulate above in the SVC or the subclavian vein area, stimulate that nerve and make sure that signal continues to reach the diaphragm and feel that diaphragmatic contraction as we are burning. If we are burning and we feel that contraction is weakening, we stop right away. And it's helpful to basically delineate the area wherever we can stimulate the phrenic nerve so we can stay away from them when we do ablation. I think we'll stop here for this session and resume next session.